Welcome to the next video focusing on third-line therapy and higher. In recent set of videos, we've been focusing in that stage 4 metastatic or locally advanced unresectable, not surgical candidates for whatever reason, also referred to as palliative therapy. I've taken you through in previous videos the approach in the first-line setting and then in the second-line setting, noting that only about half of patients move on to get second-line therapy for a number of reasons, including quick progression that prohibits any further therapy just because patients become too frail and weak to go on to get second-line therapy. And so in this video, we're going to be looking at third-line setting, and you can see there that only about a third or just less than a third of patients go on to get third-line therapy for the same reason. And you can see that there's this drop-off that occurs that is seen repeatedly in phase 3 studies when looking to see what patients go on to next. Only about 30% of patients get third-line therapy. In the most recent video, when we talked about second-line and higher therapy, specifically for HER2-positive disease, we talked about trastuzumab deruxtecan there. And so here today, though, we're going to be looking at for patients who are HER2 positive but already received trastuzumab deruxtecan in the second line can go on and get therapy in the third line setting. And certainly for those patients who are HER2 negative, who receive the rainbow regimen of chemotherapy and ramucirumab in second line, can go on to a number of possibilities in the third line setting. And we're going to look at these treatments and the evidence to use them. So again, we talked about the balancing act of controlling the cancer, treating the cancer symptoms, but at the same time trying to limit side effects of the actual therapy in order to optimize quality of life. And so if we're overdoing the treatment, but the treatment seems to be working, we talked about modifying the doses to bring us back in balance. But we've also talked about that eventually, in most cases, no matter what the line of therapy, we do expect that some cancer cells will gain the capability of resisting that therapy, and so we have to switch. So the same is true for when we start second-line therapy. Eventually, we're going to treat until there's disease progression or intolerance of that second-line therapy, despite trying to make it more manageable with dose modifications. So eventually, we're talking about switching to third-line therapy if we are able to, if patients are able to continue on therapy and if they are willing to. So the reasons to change to third-line therapy are very similar for all the other transitions we talked about between first and second line, and now switching from second line to third line. If there's obvious cancer progression despite being on that full second-line chemotherapy, with or without biologic, in this case, the biologic therapy, targeted therapy being the ramucirumab, or if there's obvious cancer progression on a maintenance regimen in that second-line setting. Say, for example, we are on FOLFIRI with ramucirumab, and we've dropped the irinotecan because of cumulative side effects, nausea, vomiting, fatigue, for example. And despite the dose modifications, every time we add irinotecan in, it becomes intolerable. So in that setting where we're on maintenance therapy, but we've seen progression, but we can't resume the full regimen, in this case, adding back the irinotecan, that would be grounds to consider switching to the next line of therapy. And then I've always qualified that sometimes we sense that there's progression clinically, even though on scans and by tumor markers, the objective way of testing it, it's not obvious, but there's a sense that there's progression. And the classic example is with peritoneal-only disease. And so in that setting, of course, we would also consider changing to the next line, third-line therapy. The goals in the setting of third line are the same as in the first and second line, and similar to first and second line therapy. Third line therapy, we're really trying to control the cancer, but at the same time limit side effects so that we can improve quality of life for a period of time. However, again, we do expect, even if it is working, that generally there will be resistance. These parameters down here are what we might expect with various third-line therapy options that we're going to go through, and this will be the summary of what one might expect, with a response rate not that high of around 3 to 5% of patients getting actual shrinkage of 30% or more. a progression-free survival of about 2 months, and a median overall survival ranging, depending on the study, between 4 and 6 months. So you can see that moving from first line to second line, there was a drop in the expected activity. And now moving from second line to third line, there's further drop in terms of what one might expect in terms of the outcomes. That said, there's a wide range around these medians, for example, and it certainly warrants trying this therapy, and we'll go through the reasons over the next few slides in terms of the evidence with each specific study. So in the principles of chemotherapy video, we talked about each of the different types of chemotherapy regimens. And in the second line setting, we talked about irinotecan and taxanes. And similarly, in the third line setting, for whichever one of these you did not receive yet in first or second line, you could move to in the third line setting, and I'll show you evidence of that. And then we're also going to introduce a new oral chemotherapy drug called trifluridine tipiracil, also known as TAS-102, which was the drug name before it received its name, and also the commercial name Lonsurf. So some evidence of smaller studies, albeit not randomized, they're phase 2 studies. And these are 2 studies, one on the left, one on the right, looking at irinotecan in the third line setting after having previously received fluoropyrimidine like 5-FU, platinum like oxaliplatin, and taxanes like paclitaxel or docetaxel. And what you can see in both of these studies, the benchmark survival is what one might expect. The darker curve is the survival curve, and the lighter curve is the progression-free survival curve. And the response rates you can see are not dramatically high. A few patients will experience a nice response, but more likely what we're going for here is at least just stability and disease control. So irinotecan is an option in the third line setting if a taxane was received in the second line. And there are some studies that support the use of taxanes in the third line setting after getting an irinotecan-based regimen in the second line setting. So what else do we have? We have this relatively newer oral chemotherapy drug, trifluridine tipiracil, and we talked about the mechanism of how it works in the principles of chemotherapy video, which I encourage you to go see. But suffice it to say, it acts to decrease synthesis of DNA. And so it acts like a lot of the chemotherapy drugs that we've been talking about. In fact, it acts very similarly in the same pathway of 5-FU. It's not the same though, and it works a little bit differently. So that's the mechanism of action. And so it was studied in this TAGS study. The study was called TAGS for third line or higher patients who had failed 2 prior lines of therapy at least. And patients were randomized to getting the trifluridine tipiracil drug or placebo. And so again, when this study was being run, there was no clear standard third line or higher option. And so it was reasonable to use a placebo to see if this agent can improve on just best supportive care, symptom management. And as you can see here, the survival curve shows a clear benefit that was statistically significant, albeit modest. You know, it increases the absolute median overall survival time on the order of a few months. But you can see here, again, the median is one thing to quote, but you can also see there's a wide range around that median, and there are some long-term survivors of this therapy. And this is the progression-free survival curve, which also showed an improvement, not dramatically when you're talking just about the medians, because the medians are not that different. You can see a lot of patients, about half of patients have a relatively fast progression, very similar to the placebo arm. But then there is some separation of the curve after that. And so some patients derive some longer standing disease control. And so this would be the reason to consider it. The response rate, though, is less than 5%. So we wouldn't be expecting dramatic shrinkage from the therapy. It's rather just there to control it and prevent it from growing. So this led to FDA approval globally of this therapy in the third line setting or higher. But you will note that these outcomes are very similar to cross-trial comparisons of single agent irinotecan or taxanes, as I just showed you. And so that's why all of these can be considered in the third line setting. So that brings us to the NCCN guidelines table for second line or subsequent therapy, and how all of these therapies are derived in either second line or third line. And now specifically, we've talked about the trifluridine tipiracil, which is listed specifically for third line. And it's a category 1 because it was a large phase 3 study. So what else do we have? We've talked about anti-angiogenesis, drugs that block the formation of blood vessels to tumors. Tumors use this pathway of VEGF receptors to enhance the growth of blood vessels towards the tumor so that they can get nutrients, but also so that they can start to seed and spread distantly within the body. And so we talked about a number of different agents that can inhibit ligands of the pathway. So these ligands would bind to the receptors and activate them. You can neutralize that with various antibodies. None of these antibodies are approved or regularly used in gastric and esophageal cancer, but they're approved in other cancers. We've talked about ramucirumab, which is an antibody that binds directly to this receptor, VEGF receptor 2, that blocks this pathway. And we talked about how in the Rainbow study and the Regard study, this established ramucirumab or Cyramza as a standard second-line option. And then today, we're also going to talk about tyrosine kinase inhibitors, multi-tyrosine kinase inhibitors. They inhibit lots of different receptors and proteins, of which including these angiogenesis receptors, VEGF receptor 1, 2, and 3. So we're going to talk specifically about apatinib and rivoceranib, and also regorafenib. So first, just a comparison between small molecules like regorafenib and rivoceranib versus antibodies. And so again, going back to the principles of targeted therapies, which I encourage you to go back and review, we talked about how small molecule inhibitors are usually not as specific as we would like them to be. And these little figures for each of these examples of tyrosine kinase inhibitors represent a whole bunch of different proteins in our body called kinases. And so this is called a kinome map or a kinome tree. And on this tree, different proteins are basically placed on the tree depending on how similar they are to each other. So if they're close to each other on the tree, then they're similar to each other. And if they're on other branches, then they're a little bit different. And so the red dots are the specific drug in every example and where they inhibit along the pathway, how many proteins they inhibit and how strongly they inhibit. So the bigger the circle, the more potent they are, the less dose they need to strongly inhibit that particular receptor. And so the point here is that these small molecules are actually quite promiscuous. They inhibit lots of different proteins. And so the example specifically that we're going to talk about is regorafenib, which has a positive phase 3 study that we'll go through, is a multi-tyrosine kinase inhibitor, inhibits lots of different proteins, but you can see at the top are listed the angiogenic receptor tyrosine kinases, VEGF receptor 1, 2, and 3. And so with this drug, you can see on-target versus off-target effects. You can have benefit from both being on target. Let's call this a angiogenesis inhibitor. It would be on target and inhibiting those receptors, but it can also have off-target effects and have some control of the cancer based on that function. Similarly, side effects can be on target. So regorafenib causes high blood pressure as a known and common side effect, which is a known side effect of anti-angiogenic receptor tyrosine kinase inhibitors. But it can also have off-target effects. For example, weight loss, anorexia, loss of appetite, which is probably due to the multi-tyrosine kinase inhibitor properties. This is in contrast to an antibody like, say, ramucirumab, which binds to and inhibits only VEGF receptor 2. And so a more cleaner drug, so to speak. It's inhibiting just that pathway. And so you can see benefit from on-target inhibition, but you wouldn't see side effects from off-target inhibition in a really targeted monoclonal antibody. So just contrasting the different ways to inhibit this angiogenesis, there are different drugs, and different drugs have different actions and mechanisms of activity, and therefore have different side effect profiles. Okay, so first we have ramucirumab, and just as a quick review, we talked about how there were two phase 3 studies in the second line setting. First, there was the REGARD study that looked at ramucirumab versus placebo, which showed benefit. But then there was the real pivotal study, the RAINBOW study, which was looking at chemo, paclitaxel, with or without ramucirumab, which established this RAINBOW regimen, PAC-RAM, to be a standard second line option. But the next question is, what about in the next line, in the third line setting? And so you can see here, this study, which was called ReExpel, is a small phase 2A study in patients specifically in the third line setting who received ramucirumab-based therapy in the second line setting. And so this was ramucirumab beyond progression. We talked about targeted therapies beyond progression when we talked about trastuzumab beyond progression for HER2 positive disease. We've shown a lot of different antibodies in that Pangea study that got treated beyond progression, if appropriate, based on the biology upon repeat sampling of the tumor. And so this is the same concept here of ramucirumab beyond progression. And the reason to even consider this is that one might say, well, why are we continuing a drug that wasn't really working anymore in the second line setting? Why would we continue it in the third line setting? Well, there is precedence for this, specifically in colon cancer, where anti-angiogenesis drugs that are used in tandem after first progression and then repeatedly in the next line had shown benefit. And so there's precedent in other tumor types. And so considering this now with ramucirumab beyond progression, this study was looking at 20 patients that were treated with ramucirumab and trifluridine tipiracil, TAS-102, Lonsurf. And so just as a pilot study to see what the outcomes would be in comparison to, cross-trial comparison to, what one would expect from the TAG study of the TAS-102 alone. And so you can see here the survival curve and the progression-free survival curves down below, and you can see the disease control rate of around 53%. And so no actual responses, but a lot of patients with stable disease. And so on the surface with cross-trial comparison, this looks like it could be promising and would need to have more investigation, larger studies, randomization to an appropriate control arm to prove that. But there is suggestion that using ramucirumab beyond progression could be effective compared to just TAS-102 alone, but adding ramucirumab to the TAS-102. Again, not a standard option, but something to consider and maybe in the future could be further developed. What else do we have? Well, again, here on this table, we see the ramucirumab studies in second line, but there were third line studies for a receptor tyrosine kinase inhibitor, multi-tyrosine kinase inhibitor called ipatinib. This study was published some time ago. It was conducted in China only, and it showed a survival benefit of ipatinib versus placebo in that third line setting or higher. This agent then sort of changed hands and changed names to rivoceranib, same drug. And this follow-up study, phase 3 study called ANGEL, was done globally outside of China to sort of see if this result would hold. And unfortunately, based on the original report, not yet published, this study was negative. And you can see there was a modest improvement in median overall survival, progression-free survival, and response rate, but this was not statistically significant and so considered a negative study. So this is an example of where one study can be done and it's marginally positive, and a repeat of the same study with the same agent, maybe in a larger scale, and still marginal benefit, but this time considered negative. So overall, we're seeing some modest activity of a multi-tyrosine kinase inhibitor with anti-angiogenesis properties, but overall negative and will probably not be developed further for gastroesophageal cancer. The evidence is shown here with rivoceranib, where you see an overall survival curve that trends a little bit, shows a modest benefit, but overall considered statistically equivalent. And the progression-free survival looks very similar, actually, if you go back to the TAGS study with Lonsurf, shows very similar acute drop in a lot of patients, not driving much benefit. But then there's some patients that seem to have some stability of their cancer for a period of time before developing progression. So again, it's similar outcomes to what one saw with Lonsurf in the same patient population, third line or higher, but overall considered negative. That's the Angel study. And this is the response rate data of the study agent regorafenib versus placebo. And you can see there is a little bit of a response rate more than placebo. First, I'll point out that there are some patients getting nothing who have some shrinkage. And so this is the importance of having a control arm that's blinded. And so you can see that there is an element of some subjectivity to looking at CAT scans. And so in some cases, it may look a little bit smaller, even though patients haven't actually received any therapy. But that said, with regorafenib, there's more patients having an actual response. So those studies showed an inkling of improvement in outcomes, but overall, taken together, this agent will not be moved further. It's not considered a standard option in the third line or higher setting. The next study, though, we're going to talk about is with regorafenib, another multi-tyrosine kinase inhibitor. It's an agent that's available already for other types of cancers, namely hepatocellular cancer, liver cancer, and colon cancer in the third line setting or higher in colon cancer. And so we're going to talk about this Integrate 2A study. So this Integrate set of studies, there's actually two of them. There's Integrate 2A and Integrate 2B. Integrate 2A is a study that's looking at patients who are in the third line setting or higher with gastroesophageal cancer, and they're randomized in a 2-to-1 fashion in favor of regorafenib versus placebo, and the primary endpoint being overall survival. The second study, Integrate 2B, is a similar eligibility in terms of the lines of therapy, et cetera. But in this case, patients are being randomized to regorafenib and nivolumab, the checkpoint inhibitor immunotherapy drug, or investigators' choice of various chemotherapy options, taxanes, irinotecan, or TAS-102, appropriate third-line control arms. And so this study was opened and accrued and completed some time ago when placebo was a considered standard option in the third-line setting. Now, of course, Integrate 2B is a more relevant third-line study where we have third-line options to choose from, to compare to. So we're going to talk now about the first study, Integrate 2A, which actually has reported in the most recent GI ASCO meeting in January of 2023. And so these were the results of that study. So again, this is regorafenib versus placebo in that third line setting. And you can see here that the survival curve, regorafenib did show benefit compared to the placebo, and that was statistically significant. And the progression-free survival was also improved, although albeit modestly. And so these outcomes, again, are very similar and numerically to what one would expect from the Lonsurf monotherapy, trifluridine tipiracil from the TAG study. So another option in that third line setting, and cross-trial comparison very similar to what one might expect with other available agents, whether it be a taxane, irinotecan, or trifluridine tipiracil. So that puts the regorafenib on the map, and maybe a matter of time before it's actually approved by the FDA. I'm not aware if this has been submitted and is under review, but it is a positive global randomized phase 3 study that warrants probable consideration for third line setting or higher. So that's what we've talked about here today then, is that there are a number of different options in that third line setting. And so part of the choice will be what has come before. And so, for example, a standard approach would be FOLFOX with a respective targeted therapy, if appropriate, and then the rainbow regimen, paclitaxel and ramucirumab. And if so, these would be options: irinotecan-based, trifluridine tipiracil, or eventually regorafenib if approved by the FDA for HER2-negative patients. Alternatively, you've heard in my previous videos that I prefer using irinotecan-based regimen in the second-line setting to limit neuropathy from the taxane, especially after just completing an oxaliplatin regimen. And so if a patient has received, say, FOLFIRI with ramucirumab in second line, then obviously in the next line setting, the options would be taxane, trifluridine tipiracil, or eventually regorafenib. It should be noted that clinical trials should always be encouraged in this setting. You can see that the benchmark outcomes based on the TAG study or the regorafenib study are only modestly better than the alternative of a placebo or best supportive care. And so this is a high unmet need. And so clinical trials here are clearly encouraged. We talked about the Integrate 2B study, which is a large randomized phase 3 study. There usually aren't a lot of phase 3 studies in this particular setting, in the third line setting or higher. Usually phase 3 studies are in the earlier setting, but there is one that you could seek to try and enroll to if you can find a site nearby. Alternatively, this is where a lot of phase 2 studies, often not randomized phase 2A studies, looking at newer agents and to see how they compare just in cross-trial comparison to these benchmarks, or even phase 1 studies. This is where one is starting to consider doing early phase studies that are first in human or first combinations in human of various agents, because the standard options are, again, modest in terms of their benefit. So in this video, we talked about the third line therapy and higher. We talked about the standard options available at this point, which include whatever chemotherapy agents have not yet been used, including irinotecan, taxane, and then we added trifluridine, tipiracil, and oral therapy, as well as new data from a multi-tyrosine kinase inhibitor, regorafenib, which has a positive phase 3 study in the global setting, and so potentially could be approved and another option in that third line setting. We talked about how we use each of these options now in tandem and dependent on what we've received prior, as well as tailoring the therapy to a patient's preference. Do we want an oral therapy versus IV? Do we want to try and spare from one particular side effect that is classically associated with one of these drugs versus another? And so there is some personalization of these treatments, but ultimately we would continue going through these lines of therapy, third line, fourth line, etc., until we've exhausted all of the available options. And then we've also talked about, of course, clinical trials are always encouraged in any line of therapy, and particularly in this third line setting where there tends to be earlier phase studies like phase 1 and 2 studies that could be used. So stay tuned for the next video, which we're now going to be talking about hospice care and when that is appropriate and the advantages of enrolling in such a program. Thank you.